morning friends. Next we are going on to discuss one of the important chapters, that is endocrine surgery. So endocrine surgery is a special super specialty topic. In this we are going to see three systems. One is Men syndrome, another is parathyroid and another is adrenal. We are going to see about these three one by one. Let us start our discussion from Men syndromes. Okay, we are discussing from Men syndromes. So Men syndrome is a high yield topic. I am not going to take it superficially, I am going to take it in depth based on Bailey and Love and Sabiston. So Men syndrome, let us discuss one by one, step by step. So first one is Men1. Men1, what is other name for Men1? Also known as Wermer syndrome. Wermer syndrome. It is also known as Wermer syndrome, and the mutation seen is truncated menin protein. Truncated menin protein mutation. Truncated menin protein mutation is present in this condition. Okay, please don't forget, it is truncated menin protein mutation. It is autosomal dominant and male and female are equally affected. Men or female, women are equally affected, and it manifests from the age of 5 years. It starts from the age of 5 years. So please don't forget, in Men 1 there is equal men and female affected. Men and female are affected equally. And it starts from the age of, the problem starts from the age of 5 years. And in this you should know there are 3P you should not forget. Men 1, when you tell Men 1, there are 3P, 3 problems associated. One is, the most common associated problem is parathyroid hyperplasia. Parathyroid hyperplasia is the most important thing, and there is pituitary adenoma. In pituitary adenoma, the most common is prolactinoma. The most common is prolactinoma in pituitary adenomas, and third one is pancreatic neuroendocrine tumors. So yes, it's a very common question. What is the most common pancreatic neuroendocrine tumor? It is gastrinomas. So this is a basic undergraduate level point what you should know from Men 1. You should never forget this at any time. So Men 1, it is truncated menin protein mutation, it is autosomal dominant, it is associated with 3P, parathyroid hyperplasia, pituitary adenoma and pancreatic neuroendocrine tumor. And when you come to each, incidence of each, about the incidence of each, parathyroid hyperplasia is around 90% of the patients will have this. It is multiglandular hyperplasia. Please remember, it is multiglandular hyperplasia. It is not a single gland hyperplasia, it is a multiglandular hyperplasia seen. It is multiglandular, and second common is pituitary adenomas. It is 30 to 40%. It is usually prolactinomas. They are usually prolactinomas. And pancreatic neuroendocrine tumor is 15%. I used to remember as 90, 30, 15. This is the percentage of these three. 90, 30, 15. 90% parathyroid hyperplasia, 30% pituitary adenoma and 15% pancreatic neuroendocrine tumors. The most common cause of death in Men1 syndrome is due to pancreatic neuroendocrine tumors. Most common cause of death in Men1 is usually due to this pancreatic neuroendocrine tumor, that is duodenal or pancreatic gastrinomas are the most common cause of death. The other problem which can happen in Men 1 is, please don't forget, there can be carcinoids. Carcinoids can also happen in thymus and bronchus. Carcinoids can happen inside the thorax. Inside the thorax. Carcinoids can happen in thymus and bronchus. This is a second common cause of death. So the first common cause of mortality is neuroendocrine tumors. The second common cause is this. Okay, these are all basic points you should not forget. And coming to super specialty level points about hyperparathyroidism in Men 1. Hyperparathyroidism in Men 1 syndrome. Regarding hyperparathyroidism in Men 1 syndrome. Please remember, it is due to multiglandular hyperplasia. It is due to multiglandular hyperplasia. This is what I first told you. It is not a single gland enlargement. It is a multiglandular hyperplasia present, number 1 point, and it is most common in second decade of the patient. It is most common in second decade of the patient, and usually in Men 1, the first biochemical abnormality in a Men 1 syndrome is, first biochemical abnormality in Men1 syndrome is hypercalcemia. hypercalcemia is the first common biochemical abnormality in Men1 syndrome. And please remember, in Men1 the glands are enlarged, all glands are enlarged, and they are asymmetrical enlargement. Please don't forget, they are asymmetrical enlargement of all 4 glands seen. So naturally, if this condition is present, we have to go for total parathyroidectomy of all 4 glands we should remove, and we can implant one gland in brachioradialis. So this is the treatment. We have to remove all the 4 glands and implant one in the brachioradialis. Another method is we can remove 3.5 gland. Half gland is left in inferior parathyroid. Half of the gland which is left is any one side inferior parathyroid. We should leave it with the titanium clip in situ. We have to mark it with the titanium clip. So hyperparathyroidism in Men1, it is multiglandular, all the glands are enlarged asymmetrically. So such patients, we have to remove all the 4 glands, or we have to remove 3.5 glands. Please don't forget hyperparathyroidism in Men1 syndrome. Very important for your exams. And when you come to neuroendocrine tumor, that is gastrinomas are most commonly found in the duodenal mucosa, not in the Zollinger triangle. So we usually say as a Passaro triangle in gastrinomas, but here it is present in duodenal mucosa. They are more commonly present in the duodenal mucosa than in the pancreas. So gastrinomas are most commonly present in the duodenal mucosa. Please don't forget this. So next, coming to Men2 syndromes. Men2 syndrome. So Men1, I hope you are very clear. Please don't forget, hyperparathyroidism is the most common thing which is present, asymmetrical enlargement all glands. So Men2 syndrome is characterized by C-cell hyperplasia will be there always. To say it is a Men2 syndrome, there will be C-cell hyperplasia will be present, and there will be medullary cancer thyroid in 100% all patients. 100% all of them will develop medullary cancer thyroid, and it is usually due to red oncogene mutation. It is a red oncogene mutation seen in Men2 syndromes. And in Men2 syndrome, if there is a loss of function of red oncogene, what happens? If there is a gain of function, what happens? If there is a somatic mutation, what happens? So if there is a loss of function in red oncogene, it results in Hirschsprung disease. Loss of function mutation is Hirschsprung disease. Gain of function mutation is Men2 syndrome. Somatic mutation is usually associated with thyroid cancers. Please don't forget, somatic mutation is associated with thyroid cancers. Various thyroid cancers. So red oncogene mutation is seen in Men2 syndrome. It can be Hirschsprung disease, it can be gain of function in Men2, or it can be somatic mutation in thyroid cancers. So now we can divide the Men syndromes into Men2A and Men2B. Other name of Men2B is also known as Men3. It is also known as Men3. Men2A is also known as Sippel syndrome. Please don't forget, these are very important points. So Men2A is Sippel's, Men2B is Men3. What are the features of Men2A? Definitely both of them have medullary cancer thyroid 100%. Please don't forget, both of them have 100% medullary cancer thyroid. And second common problem in both the cases is pheochromocytoma. Please don't forget, the second common problem is pheochromocytoma, seen in around 40 to 50% patients. So in both cases it is 40 to 50% patients. Let us assume it as 40. And pheochromocytoma is present in both the cases around 40% patients. So please don't forget this point. In Men2A, medullary cancer thyroid and pheochromocytoma are the two important lesions. So interesting point, in Men2A there is hyperparathyroidism only in 20% of the patients. Hyperparathyroidism due to parathyroid hyperplasia in 20% of the patients. Hirschsprung disease may be present in Men2A, and lichen amyloidosis. So they can also get cutaneous lichen amyloidosis, which is cutaneous lesion. These are very rare lesions. In this, you should never forget, hyperparathyroidism is 20%, Hirschsprung disease is seen. Interesting point is, in Men2B, there is no hyperparathyroidism and there is no Hirschsprung disease. In men to be, there is no hyperparathyroidism and there is no Hirschsprung disease. Instead of it, they will have mucosal neuromas. Please remember, they have mucosal neuromas are present. Mucosal neuromas are present. Marfan-like habitus is present. Marfan-like habitus is present, and they may have megacolon. So, they may have megacolon. They may sometimes have dilated colon. It does not mean it is a Hirschsprung disease, but they can have a megacolon, and there will be intestinal ganglioneuromas. Ganglioneuromas in the intestine, in GIT present. So, please remember, they have ganglioneuromas in the intestine, and very interesting point, they can have esophageal dysmotility. Esophageal dysmotility. Motility problem can happen in esophagus. These are the basic points about you should never forget for undergraduate level for writing an essay question. So, please do not forget, men to be will have neuromatic features, more neuromas, mucosal neuromas, ganglioneuromas and megacolon, Marfan features, esophageal dysmotility, all these are present along with this. So, please do not forget, they do not have hyperparathyroidism, they do not have Hirschsprung disease. So, these are the points in men 2A and men 2B. So, what are the other tumors they can get is, apart from medullary cancer thyroid and pheochromocytoma and hyperparathyroidism, please remember these are very important points for your exams. Okay. So, in this, one important thing I want to tell you is about the medullary thyroid cancer. Medullary thyroid cancer. Medullary cancer of thyroid is a deep discussion needed in this chapter. So, medullary cancer thyroid can happen due to various causes like familial medullary cancer thyroid syndrome. Familial medullary thyroid cancer syndrome. It can happen in men 2A patients and it can happen in men 2B patients. So, these are the three important genetic causes of medullary cancer thyroid. So, 75% of the cases are sporadic. Please remember, 75% cases are sporadic. Only 25% is genetic or hereditary. The genetic causes I am telling. In all these cases, what is the mutation? In all these cases, there is red oncogene mutation. In all these cases, the main mutation is red oncogene mutation. In familial mutation, in familial medullary thyroid cancer, the mutation is present at exon 618. It is present at exon 618 is familial medullary thyroid cancer. In medullary thyroid cancer, men 2A type, it is at exon 634 mutation. It is 634 mutation. In men 2B, it is very easy to remember, it is 618 here, here it is 918 here. So, it is 918 here. Please remember, it is 918. Here it is 618. 618, here it is 918. Please do not forget this point. In men 1, it is familial medullary thyroid cancer 618. In men 2B, it is 918. And men 2A, it is 634 mutation. So, men 2A mutation is men 2A and men 2B. Men 2B is an aggressive form. They develop cancer very fast. So, we have to do prophylactic total thyroidectomy before the age of 1 year you should do. In men 2B, 918 mutation is present is aggressive form, whereas men 2A we have to do at 5 years. This question is a very interesting question. Please do not forget this. So, men 2A, men 2B, which is more aggressive? Men 2B is more aggressive. Therefore, we do prophylactic total thyroidectomy before 1 year. Men 2A is less aggressive, so we can wait up to 5 years for prophylactic total thyroidectomy. Okay. So, now what are the other points? So, these hereditary cancers, what are the features of this hereditary type of medullary thyroid cancers? Hereditary cancers are multifocal and bilateral, very important point. They are usually multifocal and bilateral, and they do not take up radioactive iodine. They do not take up radioactive iodine, and survival is 70% at 10 years. And they have extensive lymph node metastasis. Usually hereditary type will have more than 75% will have lymph node metastasis will be present. We have 75% will have lymph node metastasis, and we have to do total thyroidectomy with the central neck node dissection. And what is the treatment we used to discuss? Total thyroidectomy plus central neck node dissection plus modified radical neck node dissection of the involved node side. So please remember hereditary type. We have already discussed medullary cancer thyroid in thyroid cancers, but here remember in hereditary it is multifocal, multicentric and has more lymph node metastasis. Coming to pheochromocytoma in Men2 syndromes. Pheochromocytoma in Men2 syndromes, hereditary causes. Pheochromocytoma is a tumor arising from adrenal medulla. We all very well know it arises from adrenal medulla. The tumor arising from the adrenal medulla is pheochromocytoma, and pheochromocytoma is seen in around 40 to 50% cases of both Men2A and Men2B, and the age of diagnosis is usually 20 to 40 years. Age of diagnosis is usually 20 to 40 years, pheochromocytoma. So the interesting point is these type of genetic hereditary associated cases, hereditary pheochromocytoma has an interesting point like this before. So please remember the points are: normal pheochromocytoma is known as 10% tumor because they are 10% malignant and 10% extrarenal. These cases associated with Men2 syndrome is mostly benign. Is benign always. It is benign always. There is no 10% malignant. So interesting point. Pheochromocytoma in a genetic background is benign always. It is benign always and only seen in adrenal gland. There is no extra adrenal gland. It is seen only in adrenal gland. So normal pheochromocytoma is 10% extra adrenal, 10% malignant, but hereditary pheochromocytoma is benign always and it is seen only in adrenal gland. And interesting point is it is bilateral and multifocal. Bilateral and it is usually multifocal. So please don't forget these 3 points in hereditary pheochromocytomas. I will again ask you this. So the treatment advised for these cases is adrenalectomy. We don't remove both the adrenal like in hyperplasia of parathyroid. In hyperplasia of parathyroid, we remove all the 4 parathyroid. No, like that we don't remove here. We remove only affected gland is removed. Only affected gland is removed in these cases. Because in those days they were doing bilateral adrenalectomy for these patients that resulted in severe adrenal insufficiency. So therefore nowadays we are not doing total removal. We remove only the involved gland alone we are removing now in hereditary pheochromocytoma. So please don't forget this point. This point you should not forget. So pheochromocytoma, what you should do? And I already told you medullary thyroid cancer and pheochromocytoma are the 2 important lesions in Men2 syndromes. And there is one rare syndrome known as Men4 syndrome, not given in your books. It is from super specialty books. It is due to cyclin dependent kinase inhibitor mutation. Cyclin dependent kinase inhibitor mutation in chromosome 12. So the interesting point is they all have parathyroid adenomas. They also have parathyroid adenomas, not hyperplasia. This is parathyroid adenomas and pituitary adenomas. They have parathyroid adenoma and pituitary adenomas. There are 2 adenomas, 2P, parathyroid and pituitary adenomas, and this is taken from urology super specialty books because they produce renal tumors. It is taken from urology super specialty books because they produce renal tumors and reproductive organ tumors like testis and cervix. They produce tumors in reproductive organs like testis and cervix. So this is Men4 syndrome. This is a Men4 syndrome not given in your textbooks. It is from super specialty books. There is a cyclin dependent inhibitor mutation at chromosome number 12 and it is associated with the parathyroid adenoma and pituitary adenomas. They have renal tumors and reproductive organ tumors. They have renal tumors and reproductive organ tumors. So now see the images from this chapter right to discussed. So you can see this is a typical parathyroid hyperplasia. You can see all the 4 glands are asymmetrically enlarged in Men1. In Men1 there is asymmetrical enlargement of all the glands. How many percentage of them will have hyperparathyroidism? In Men1, 90% will have hyperparathyroidism in Men1. It is a asymmetrical enlargement. In Men2 syndrome, hyperparathyroidism, hyperplasia is seen only in 20% of the cases. And Men2B, there is no parathyroid involvement. Please don't forget these points. And I will again tell you, the mutations in 618 is associated with familial medullary thyroid cancer. In 634 associated with Sippel syndrome. 918 associated with Men2B. 918 cases need thyroidectomy at 1 year, and 634 mutation needs thyroidectomy at 5 years. Prophylactic thyroidectomy. So you can understand Men2 syndromes 100% will develop medullary thyroid cancer. At 1 year we should do prophylactic total thyroidectomy, and in 5 years we should do prophylactic total thyroidectomy for Men2B syndromes. Okay, please don't forget all these points we have discussed. So Men4 is a cyclin dependent kinase inhibitor mutation. So that completes the Men syndrome.